I'm going to record.
Okay.
Okay, this
Turn that down. Everybody be on mute, please. Good?
I think so.
All right. Good afternoon, everybody. We
Recording
thank
in
you.
progress.
We had to take a couple minutes to make sure we got everybody assembled in the room. I'm Christy Putnam, Secretary of the Arkansas Department of Human Services. Most folks here know me. I know we have a lot of people joining us online today. We've already dropped in the chat the request for if you are attending for someone else, if you're a designee of a member of this advisory group, please make sure that you identify who you are representing on this meeting, because we are working to document participation in these meetings. I just want to say thank you, welcome to all of our partners and providers and everyone who is online. We appreciate everybody joining for this discussion. This is our quarterly update, the Health and Economic Outcomes Accountability Oversight Advisory Panel. And, we welcome anybody to join. This is a public meeting, so if there are others who you all know, those of you in the room or those of you online who might be interested in getting these updates and hearing these meetings, please let them know. Please feel free to send us their name and we'll add them, or feel free to share the invitation as well. So we are going to jump into our agenda here. In just a moment, we follow the usual format where we look at the results of the quality metrics, and then we go through different penalties and beneficiary surveys. And as you can see, everything covered on the agenda. But before we dive into that, if I don't get the chance later, I just want to make sure to wish everybody a very Merry Christmas, happy holiday season, and we're looking forward to working with everybody again throughout the 2025 plan year. So with that, I will turn it over to Nell Smith.
All right. Hi, everybody. I'm Nell Smith. I'm the Deputy Director of the Division of Medical Services. Just a note that welcome to everyone, but in particular the panel members. As Secretary Putnam said, we are taking attendance because there is an Act 276 of 2021 that requires DHS to take and report attendance of advisory panel members. And we have to report that information 2 years from now for the attendance for all of the meetings. So again, if you're an advisory panel member or a designee of a member, please make sure that you let us know in the chat. Another reminder that Arkansas PBS is live streaming now. You can watch, some people may be watching via live stream, or you can watch it later if you so desire. Also, a reminder, we normally have a section of this meeting where we go over the statutorily required quarterly report. But we've got such a full meeting that we're not going to do that this meeting, but it will be posted online, and we will send the report out to the panel members following the meeting, along with all of the meeting materials. This meeting is focused on the second part of the Health Improvement Initiative. We did many metrics in the September meeting. We are going to continue the rest of the quality measure review. We will review the potential financial penalties for failure to meet targets, and then we'll review the plans for incentive improvement. Then we'll give the QHPs the chance to review their strategic plans for the 2025 plan year.
And we're also recording.
Oh yes, we're recording via the PBS, but also we are recording this Zoom meeting. Thank you. Mm-hmm. Oh, and as always, I'll say, please feel free to jump in. I have not been very good in the past about paying attention to the chat messages, so we've got a system so that somebody pokes me if a chat message comes up and I miss it. You can chat, that you can ask the question that way, or you can unmute yourself and join the conversation, whichever you prefer. I prefer people participate so that people are not hearing my voice the whole time. And Jen Dedman. I should introduce Jen. Jen, you want to introduce yourself?
I'm Jen Dedman. I'm going to be working with Mel and eventually hopefully taking over the care of the ARHOME program. And I've been with CMS in other capacity for a couple of years now.
So she's going to be jumping in on some of these slides as well. So this is a reminder slide from the last meeting, just kind of an overview of how we see the ARHOME accountability system working. We've got measures, incentives, targets, and penalties. So the measures are, for example, the percent of women who received a mammogram. Then the incentives, we ask the QHP to offer incentives to beneficiaries or providers. So they could, for example, offer $50 for beneficiaries who receive a mammogram. Then we set targets that the QHPs must meet. So, for example, we might set a target that says QHPs must ensure that at least 54% of women receive a mammogram. And then penalties. So we'll say if on the whole of all of these measures and targets, you're not meeting enough of the measures, then we'll assess a per member per month penalty, and you'll see that at the end of this presentation. But those are the 4 core parts of our accountability, and that's how why we're talking about measures and incentives and targets and penalties all in the slides today. So this is an overview of panel activities just to catch everyone up. In December of 2022, we set the 2023 performance targets for the health metrics. We based that on 2019, 2020, and 2021 performance results. So,
I forgot you left.
Oh,
All
Mitzi,
right.
Mitzi, I think you have your, you need to
Well,
mute.
I know the problem. The problem is I don't know how, but my speaker at the bottom is off. It says no audio device.
Mitzi, we appreciate your attendance.
Matters in your own hands. Must have been a cheap present.
So at any rate, the point that I wanted to make here is that we set the 2023 performance targets way back in December of 2022. In September of 2024, we reviewed some of the performance metrics, and we reviewed the results of some of the health incentives that the QHPs offered. In December of 2024, that's today, we are continuing to review the performance results. We're reviewing potential sanctions for the 2023 performance. We will set the 2025 performance targets. That's a work in progress, but that will be done before the end of the year. We will sign an MOU with the QHPs, and those performance targets will be part of that agreement. And then we're continuing to review the 2023 health incentives and the proposed 2025 incentives. We're in 2024 now, so there's already some incentives in the works, but they're going to propose the 2025 incentives for us to review and sign off on before the plan year starts. We also will be reviewing the beneficiary engagement survey results. And as I said earlier, the QHPs will present their strategic plans. So I went over the 4 main parts of our ARHOME accountability. This is the requirement for the incentives. Yeah, in 2023, the QHPs were required to offer 2 health improvement incentives for each focus area. And the ones that are in color are the ones that we will review today. The ones that are in black are the ones that we reviewed in September. And the QHPs must include activities to support in their strategic plans. They must include activities to support the health improvement initiative. So you'll be hearing more about that when they present in a minute. Again, this is the targets are another component of our accountability, and just to sort of help you understand the target setting methodology, we have 3 targets that we've asked the QHP to meet for each measure. They include a best performance target. So we looked at the best performance of the QHPs in the last, for 23, we did, no, that's right, we did 2019 through 21 for the 23 targets. So you can see in the sample measure, the one that's in green is the best performer of all of the different measures, all of the different years. and QHPs. And the yellow is the median target. That is something the QHPs asked for as if they can't meet the very best performance, maybe they could get some points for meeting a median. So we set a median target, and then we set an improvement target, and that is each QHP has its own target for improving its best performance by 4%. And it's not 4 percentage points, it's 4%. Each target is worth an established number of points that we set out in our agreement with the QHPs, and the total number of points that a QHP receives determines whether it has a financial penalty and the amount of that financial penalty. The target that you'll see on the slides, because we have 3 targets, it gets a little busy to put all of the different targets on the slides. You'll see the slides are pretty busy as it is. So we have just gone with the best performance targets. So you won't see, we'll have some information on the other targets at the end of the presentation, but there will be a black target on each slide, and that is the best performance target. This is just a reminder, again, the QHPs will say, oh, we can't do as well in these areas because our population is sicker, or our population is older, or our population is something. And this was an exercise to demonstrate where were the differences. We found that by and large, the populations are similar across the QHPs. The red line is ARHOME overall. The 2 blue lines are for Blue Cross and Health Advantage. And then the 3 green ones are the Centene plans, and Better, QCA, and Qual Choice. Overall, the plans are similar in their demographics, except with the area of age. And you'll see that Health Advantage generally has a younger population than the other QHPs, and Better and Blue Cross generally have an older population than the other QHPs. Okay, so the first measure that we're going to start with is contraceptive care. So we're going to look at contraceptive care for postpartum women and for all women in reproductive age. So this slide shows the ARHOME overall rates in red for each year from 2019 through 2023. The black and white beneficiary rates are in different shades of blue, and the urban and rural are in different shades of green. And you'll see this pattern for all of the measures that we'll be looking at. We also have the target, as I mentioned, displayed in black. That is the best performance target, not the improvement target or the median target, but the best performance target. So this is contraceptive care for all women 21 to 44. And this is those who were provided the most effective or moderately effective method of contraception, and those include LARCs, long-acting reversible contraceptive methods, such as implants, IUDs, as well as irreversible surgical contraception. And then moderately effective methods include injectables, oral pills, patches, rings, or diaphragms. So that's the measure. You can see that we have had a decrease over the years, a steady decrease. That's not the way that we want this to go, but this does align with national trends. Medicaid median rates have been steadily dropping since 2019, and we'll take a look at postpartum in a second. One of our researchers has identified a study that indicates that perhaps the decline is related to the healthcare workforce, that there's a diminishment in OBGYNs nationally, and that is the access point for these contraception methods. So Black women have had higher contraception rates than white women overall for at least the last 5 years. Rural and urban women have about the same contraception rates overall. And we're doing about the same both in our ARHOME population and in Arkansas Medicaid overall, with the median of Medicaid reporting states. So this is a look at the same measure, but for the QHPs. And you'll see this slide and this pattern throughout the presentation. This includes each of the QHPs at the bottom and the ARHOME overall, and then the different years are in the different colors. And the target across the top is just the 2023 target. It doesn't include the 2022 target that we established. So you'll see that the QHPs declined over the 3 years, except for Health Advantage, which you might remember is the QHP that has a younger population. Health Advantage has improved over the 3 years and outperformed the other QHPs in 2023. Health Advantage also started in 2021, so it was really building its population in that first blue year. This is contraceptive care for postpartum women. So this is women who have had a live birth who were provided contraception within 90 days of the birth. Just a little note about these slides in particular. I have adjusted the scale on these slides so that you can see differences in the patterns. So something might look like a giant increase or a giant decrease, but it was so that we could see differences. So sometimes it's helpful to look at the scale to see, how big a difference is that really? But you can't see them if you squinch them all together. So, and another thing to point out is that in 2019, 2021, and 2019, 2020, and 2021, the measure looked at postpartum for contraceptive use postpartum for 60 days. And then in 22 and 23, the measure changed to 90 days. So that's why you're seeing the increases in 2022. It's not really, it's a measure change rather than a true increase. But you'll see that leveled out in 23. And we have rural is doing better in this measure than the urban population. And we had a big improvement in the Black population, which may be the result of smaller denominator, smaller populations, so that any one person can change that value fairly easily. But it is still a question for us to further research. Okay, so this is same measure but for QHPs. Shows the QHP results, and you'll see that even with the additional 30 days included in the metric, beginning in 2022, none of the QHPs met the 22 target. They didn't meet the 22 target. They didn't meet the 23 target. And the 3 Centene plans had the highest contraception rates among postpartum women. This is a slide that summarizes. I'm going to skip past this. This is for people who weren't able to make it today. Okay, so birth outcomes. We have 3 birth outcomes. We have preterm births, low birth weight, and very low birth weight. We're just going to look at 2 of those today. One thing to note, I'm glad Mitzi is here. Our friends at ADH helped us with these measures. And I should say that Optum helped us with all of these measures. Optum calculated these measures for us. They're one of our vendors. But ADH allowed us to give them our Medicaid data, our Medicaid enrollment. They matched it with birth certificate data and gave it back to us, and that is how we were able to calculate these. So we're very thankful to ADH for helping us do that. So this is just a introductory to the birth outcome data. This is 5 years of Arkansas births, and you can see that we have about 55 to 60% of the births in Arkansas are funded by Medicaid. That went down in 2023, most likely due to the unwinding of the public health emergency. That was during COVID, we were not allowed to disenroll anybody except under certain circumstances. In 2023, we unwound that requirement and began disenrolling people who were no longer eligible for Medicaid. So we see a drop in the percentage of all of the births that were Medicaid funded. This slide shows same years, but it's just Medicaid. So we do see a decrease in Medicaid funded births over the 5 years. The red at the bottom is of the Medicaid births, which ones were ARHOME births. And you can see during the COVID period, 2020 and 2021 and 2022, we saw an increase in ARHOME births proportionally to the rest of the Medicaid births. And that's because if you are new to Medicaid and you're pregnant, you would be put into a different Medicaid category, not in ARHOME. But if you were in ARHOME and became pregnant, you would stay in ARHOME. So we think this is a matter of people remaining in ARHOME so that when they become pregnant, they're staying in ARHOME. Then 2023, the dip there we think is related to obviously the public health emergency unwind when we were disenrolling people. That caused people to come back. When they came back, they were new applicants applying they would be put into the pregnant women aid category. All right, so this is our preterm births number, and this is a little bit of good news here. We've got the preterm births going in the right direction, declining in 2023. Those rates had been stagnating for a while, but we saw some improvement. We're not exactly sure what to tie that improvement to, but we'll take it nonetheless. Okay. We also have disparities that continued, disparity between the white and black populations. Blacks have a significantly higher preterm birth rate, and that is something that needs to be addressed. All right, so this is preterm births by QHPs, and all of the QHPs preterm birth rates improved, and the And Better plan had the most significant improvement and the best rate. This is low birth weight, and this is the percentage of babies born less than 2,500 grams, which is about 5.5 pounds. We're seeing sort of mixed, an overall improvement, slight improvement in a dip in the overall numbers, but we had some increases in the white population, a little bit of an increase in rural and the black population, but overall it's another one that's good news. Okay, this is low birth weight by QHP. The results were mixed for low birth weight measure. The rates for 2 of the Centene plans, QCA and Qual Choice, and one Blue Cross plan, one of the Blue Cross plans worsened, while the rates for Health Advantage and And Better improved. And Better had significant improvement, just like they did in the last the last measure, the preterm births. And again, they had the best rate for this birth outcome. This is the summary for the folks who couldn't attend. All right, incentives.
So what we're seeing here are the 2023 improvement incentives for pregnant women. You can see the Blue Cross plans are in blue and the Centene plans are all in green. These are the incentives that were offered for the 2023 year, and you can see here the percent and number of beneficiaries awarded and the total amount awarded for these. Go ahead and advance the slide. And here we're looking at the 2025 proposed improvement incentives for the same category. You'll see that the incentives for the Blue Cross programs are the same. And for Centene, in addition to the community baby showers, which we saw in 2023, we've got this Farm Box RX program, as well as a provider notice of pregnancy incentive for providers.
And QHPs, if you want to shout out, shout out.
Happy to speak a little bit about our two new ones there. The Farm Box program is a food program where our pregnant moms actually, by signing up for the Farm Box program, allows us to collect a lot of what we call notification of pregnancy information, gets us some potential due dates. We also capture any other comorbidities that might impact that pregnancy so that we can target that member with information and make sure they're receiving the proper care throughout their pregnancy. It allows them to get, just signing up gets them a food box when they start and a food box at delivery. And then there's some additional food boxes they can earn in between that by completing certain activities such as getting an ultrasound, having their glucose tested, participating in our Start Smart for Baby case management program. We are looking, this year it was 4 boxes. We are looking at maybe expanding that in 25 to add an additional 2 boxes throughout the pregnancy. So it is a program we've seen a lot of success with, and we're looking to build upon that program in 2025. The $100 provider notification of pregnancy, that's just another opportunity where we feel like the sooner we know about someone's pregnancy, we're able to collect that information to know how to target that member for any special circumstances they may have to help reduce those preterm deliveries. This is just another incentive directed at providers. So another way for us to get that information is to incentivize providers when they are seeing those members to also provide us that notification of pregnancy. We may get it twice. We may get it from the member, we may get it from the provider, and that's just fine. But the sooner we can get that, the better.
Thank you.
And I'll speak for Blue Cross. We're doing something too around notifications of pregnancy. We are on our rewards platform asking members to tell us if they're pregnant, yes or no. And then based on their response, they'll be triggered for the $225 of possible rewards by connecting them with services. Also with our prenatal visit reward, we're being more explicit about recommending an additional visit, trying to encourage that continuous care throughout pregnancy, not one and done, but for 4 visits. So it will remain recommended to go attend a visit, even if they completed a visit. I think right now it looks more completed once they start, going to the doctor and having a prenatal visit, but next year it'll show like 1 of 4. And so they want to finish and get the full $200. So we're being more explicit about that.
It's not on this slide, it might be on another slide, but there is an incentive payment per visit up to 4 visits, and it looks like you're recommending an additional visit this year, and that's what equals out that total possible amount.
Well, and it's 4 visits, but then $25 comes from our virtual platform if they were to engage with that, or talking to one of our case managers that are under maternity.
Thank you.
Yeah, sure.
And I'll just add for our panel members, the QHPs and DHS are working together to create a file exchanged every day that identifies women who are pregnant, that they've identified through claims or diagnosis codes who are pregnant. In part, that's so that we make sure that none of those women have to pay a copay for anything. We've got other methods of ensuring they don't pay a copay, but this is another avenue for doing that. But the end goal would be to ensure that we get that information over to our eligibility team so that they make sure that those women maintain Medicaid eligibility throughout the pregnancy. Okay, hospital readmissions. So this measure is, and this is one of those that I think looks more dramatic than it really is. But again, I've adjusted the scale so that you can see what was going on. This is there is an expected number of hospital readmissions that a population might be expected to have based on the characteristics of the population, a statistical calculation of expected hospital readmissions. And this is a ratio of hospital readmissions to actual hospital readmissions. So if you had a ratio of 1, that means your expected readmissions is what would be statistically expected for your population. So lower is better, but we around here sort of think about as long as you're under 1, you're doing better than what is expected. And again, the scaling here is just to be able to show you differences, but it's so it makes it more dramatic. But we have had an uptick, but we are still under the 1. So our hospital readmissions for all populations is lower than what is statistically expected. This is the same thing, but for the QHPs. And you will see that we saw some improvements or no change in the Centene plans and worsening rates in the Blue Cross plans. But again, they were right at 1. There's slight 0.0007 above, but at or under 1. This is substance use disorders and mental health. The first measure is substance use disorder treatment, initiation of that treatment. We've got a similar measure that's continuation, but this one is for the percentage of clients with a new episode of substance abuse who initiated substance abuse treatment within 14 days of the diagnosis. And the treatment includes inpatient alcohol or other drug admission, outpatient visit, intensive outpatient encounter, or partial hospitalization, telehealth, or medication treatment. Overall, the ARHOME SUD treatment initiation rates are improving. White beneficiaries had higher rates of SUD treatment initiation than Black beneficiaries for all 5 years, and that disparity is worsening. The urban rates of SUD treatment initiation are outpacing rural SUD treatment initiation, and that was a change that occurred in 2020 and 2021, where they swapped places, and you'll see that also in the next measure. And the white clients initiate treatment at significantly higher rates than Black clients, and that aligns with national Medicaid data that also found nationally that lower SUD treatment rates for Black enrollees than for white enrollees. So unfortunately, that's not just Arkansas. This is the same measure, but at the QHP level. There's little difference in the SUD treatment initiation rates between QHPs, but 2 of the Centene plans met the target. Oh no, sorry, more they all met the target, yeah. Oops, my on engagement. No, I'm on engagement. Okay, this is engagement. So this is related to the previous measure but it is a look at those people who initiated treatment and then were still engaged in treatment within 34 days of the initiation visit. So about 43% of individuals with a new episode of SUD received treatment within 2 weeks, but only about 13% continue to be engaged in treatment for a month. And I'm going to show you a slide on that that compares those two in just a second. But just like the initiation of treatment, ARHOME overall continued to improve in the treatment engagement, which is good news. Oh, sorry. Also, white clients have higher rates than Black clients, similar to the previous measure. Urban rates of SUD treatment engagement are outpacing rural. And again, that switch, that change occurred in between 2020 and 2021. It used to be the other way around. And ARHOME and Arkansas Medicaid overall have lower SUD treatment engagement rates than the national median rate for Medicaid reporting states. This is the same measure, but for the QHPs. And while 5 of the QHPs met the established target, but there was little difference in the rates of Ambetter clearly did better on this target than the other QHPs, but very similar for the other ones.
Do we know how much different it is from Arkansas from the national rate of
Yes.
engagement for SUD treatment?
Yes. Engagement, yes. So the Medicaid median is 17, oh good, this tiny little, 17%, and ARHOME is 13.6%,
Okay.
and Medicaid overall is 11.9.
Thank you.
It's thanks to Adrian Nivola, put that together for us. Okay, so I promised this fantastic slide that shows that very wide gap between initiating treatment and in staying engaged 34 days later. They're both improving, but there is still this gap. It seems to be true for a lot of the measures where we have do something first and then stick with it. We have the same pattern. Okay, this is for the folks at home.
Okay, and we're back to two of the improvement incentive slides. This again is the 2023 improvement incentives for substance use disorder. And you can see here that we have it divided by the Blue Cross plans and the Centene plans again, and you can see the number of beneficiaries awarded in percent and the total awarded. Again, if you were at our last quarterly meeting, you've seen this slide. This is 2023. So go to the next slide, please. These are our proposed incentives for 2025 by QHP. So you'll see here that the Blue Cross plan is still offering the $100 for the completion of a follow-up visit, but the $50, it seems to be a broadening of the activities that you can do to receive that $50. For the 2023 plan, you would need to complete a follow-up visit or receive medication-assisted therapy within 14 days and attend 2 follow-up visits. Now, that's $50 for members with a substance use disorder who use the peer support specialist, virtual SUD treatment, or other SUD treatment options. And then for Centene, we don't have a specific incentive for the substance use disorder, but we do have some programs. We have the pharmacy lock-in program and transitional care management programs. And if either of you want to speak to your programs for substance use disorder, please let us know.
I think you described it well, Jen, and also we're going to display this incentive throughout the entire year if we know that they have a history of substance use disorder. So just more awareness, trying to promote all of our programs.
Great, thank you.
I will speak a little bit more in detail about these programs in the strategic plan, so I'll just say that for that.
Right, and they'll be presenting their strategic plans later this meeting.
Yes.
Yes, so they will have an opportunity to speak more about this shortly. I'm really kind of stealing your thunder. All right.
And I also wanted to mention, you asked about the Medicaid rates, and I should have mentioned that we don't have yet the national Medicaid data for 2023. So the data that we're comparing ourselves to is 2022. So
Okay.
want to make that
Good point.
that clear. Okay, mental health. So the first measure is antidepressant medication management in the acute phase. So this is the percentage of beneficiaries diagnosed with major depression who were treated with and remained on antidepressant medication for 12 weeks. So the ARHOME program had improvements in antidepressant medication management in the acute phase in 2023. White rates, as with the other mental health measures, white rates are significantly better than black rates. Rural and urban rates were similar, but the urban rates were slightly higher than the rural rates. And our home rates for 2022 are better than the Arkansas Medicaid overall rates and just slightly below the median Medicaid reporting states. Okay. So this is the same measure, but for QHPs, and you'll see there's not a lot of difference among the QHP rates, with the exception of lower rate for Health Advantage compared with the other QHPs. This is a similar measure, but this is the continuation phase. So this is the percentage diagnosed with major depression who were treated and remained on antidepressant medication for 6 months. So previous one was 12 weeks, this is 6 months. So while the ARHOME program had improvements in antidepressant medication rate in the acute phase, the rates declined in the continuation phase. And I have another fun slide that shows you that. But again, significantly lower rates for Black beneficiaries than for white beneficiaries, and a similar rate for rural and urban beneficiaries, but the urban rate is just a little higher. Oh, and I should say that our home rates are better than Arkansas Medicaid overall rates, and just slightly below the median of the Medicaid reporting states in 2022. So this is same thing, but the continuation phase. Same measure, but QHPs, and not a lot of difference among the QHP rates, with the exception of lower rate for Health Advantage compared with the other QHPs, and that's similar to what we saw with the acute rate. The Blue Cross plan also had a little higher rate than other QHPs. This is the slide I promised, comparing the acute phase to the continuation phase. So the improvement in the acute phase and the worsening of the continuation phase resulted in a widening of the difference in these two related rates. There was a 26 percentage point difference between the acute phase rate and the continuation phase rate in 2023. And that obviously that difference is widening. In 2019, there was a 16 percentage point difference, and now it's 26 percentage point difference.
So question to our QHP partners, when somebody presents acute and they're on their medication, and then we see this drop off for continuation of their meds, do you all get information from the providers about what efforts they're making to make sure that they're continuing, or to encourage them to continue on their medication? Is that part of the follow-up information you all collect, or do you not get that granular? Is it just this, it is what it is?
We're asking our members barriers to not taking it. We're trying to educate about the importance of staying on the antidepressant for longer to see a benefit. So we're focusing on member education. Next year, we're going to start really focusing on provider communication along with our members and aligning that closer. So I do think providers are a big part of that as well. And we're going to be looking at that
Next year,
for
being
next year.
2025 plan year.
Yeah.
Okay.
Percentage, I think that if we look at the years when this was impacted, we'll see that there may have been several members initially assigned an antidepressant medication that was not prompted, warranted, or needed, and therefore they're not going to continue through the continuation phase.
Sure.
And because we're not allowed to utilize medical record abstraction and contraindication notes, then there's no way for us to determine if that need is still present. So instead, we just appear to be non-compliant members that probably should have been medicated anyway. So that's going to be a hang up.
Thank you. Dr. Golden, did you have something?
No, I'll pass.
Okay, okay.
Too much in the weeds.
Okay, so this is follow-up after an ED visit, an emergency department visit for mental illness. So this is the percentage of emergency department visits for beneficiaries with a principal diagnosis of mental illness or intentional self-harm who had a follow-up visit with a mental health care provider 30 days after the ED visit. So the ARHOME program's follow-up rates for mental illness after an ED visit remained about the same. White rates for treatment for mental illness were significantly better than the black rates for this measure. And both ARHOME and Medicaid overall are below the Medicaid mean for reporting states. So this is the same measure, but for QHPs. And we can see that nobody's meeting the target, but we had some strong improvement in QCA and better, and some declines, and Blue Cross, and some declines in Health Advantage and Qual Choice. This is, so the last measure was follow-up after an ED visit for mental illness. This one is follow-up after hospitalization for mental illness. And this is the percentage of hospitalizations for beneficiaries who were hospitalized for treatment of selected mental illnesses or intentional self-harm diagnosis who had a follow-up visit with a mental health provider 30 days after discharge. And we have a significant spike in 2020, and that was an increase because this is a measure that's follow-up care. We think that telehealth may have caused that spike in 2020. Now you might expect that would continue on into 2023. But we certainly think that was what was going on in 2020. The ARHOME program's follow-up rates for mental illness after an ED visit remained about the same, but the follow-up rates for mental illness after hospitalization improved. And while rates for treatment for mental illness were significantly better, white rates were significantly better than black rates for both follow-up measures for the hospitalization and ED visit for mental illness. And we had that significant drop in black beneficiaries, while other populations improved. And we're not exactly sure what's going on there. It may be due to a small denominator that caused a big swing with one or two people in the numerator. But right now we don't have a good answer for that. This is the same measure, but for the QHP population, and you can see that we had improvements across the board, some higher than others, but certainly we'll take any improvement. This is for the folks at home.
We're looking here again at the 2023 incentives, this time the improvement incentives for mental illness. And I want to highlight just a couple of things that are going to be changes for 2025. The Blue Cross programs, we have these two beneficiary awards here, $100 for completion of a follow-up visit 30 days after a hospitalization for mental health disorder, and $50 for remaining adherence to an antipsychotic medication throughout the year. And for Centene, we have here listed, I want to highlight the My Health Pays portal. If you'll go ahead and move forward to 2025. Centene, I believe the My Health Pays is still happening. It's just not on this slide. We do have listed case managers, digital case management, and a value-based care program looking forward to 2025. For Blue Cross, we now have a $50 incentive for members with behavioral health diagnoses to receive if they complete a visit with a mental health provider and attend a follow-up visit. For 2023, what we're looking at was $100 for completion of a follow-up visit 30 days after a hospitalization for a mental health disorder. So different criteria, different award there. And then rather than the $50 for remaining adherent to an antipsychotic medication throughout the year, we now have a $60 using tools for remembering to take your mental health meds award. And that's a $20 per adherence tool use. So we're seeing some differences in the Blue Cross incentives for 2025. Okay, these are the overall QHP results. What we're looking at here is every measure that we've already seen on all of these charts, and this is an overall look at how our QHPs meeting these 3 targets. The targets you were looking at, the black line on all of these slides, would be your best performer target. So that line that we were trying to meet on the charts, that's the column to the far right. We also have here the median and the 4% improvement targets. You'll see that green means that they met or all QHPs met or most met. The red means that most did not meet or no QHPs met, and then mixed results are in yellow. We have a couple of areas of strength. Now if you can advance, I think it might be right here. All QHPs met all 3 targets in the areas of asthma medication ratio, initiation of substance use treatment, and engagement of substance use disorder treatment, as well as follow-up after emergency department visit for alcohol and other drug abuse. So those are the areas of strength that we noted where all QHPs met all 3 of the targets. A couple of areas of challenge you can see on this slide. We've got hospital admission rate for heart failure. And I think if you go forward to the next slide, another area of challenge is antidepressant medication management continuation phase, not acute.
I also am not sure, I think Zoom does not like red because all of those are blurred, but they are clear on the screen, so I apologize for that.
And here we have our annual penalties. So because it is the end of the year, we were able to look at the performance and total up incentive points that were established in our MOU for the previous year. We had, and I believe that there's a chart available on our quarterly report if you'd like to have a really close look. But in approximately 10-point blocks, you had a score that was available, and I think it was for 40 to 49 points total, and below, there was a penalty that would accrue. So you can see here that most of our QHPs did not accrue a penalty. We met the points for each of the categories. Only one QHP does have a penalty, and I want to go ahead and address that Health Advantage note there. Health Advantage is a newer plan. There are a couple of measures that have a 3 or a 5 year look back period. Those points were not available for
These actually, we did not have 2021 data for Health Advantage for
3
preterm
measures.
birth, low birth weight and asthma medication ratio. So we didn't have a score at the time that we were setting up the MOU for Health Advantage. So
right.
Yes.
So essentially, those points, there were four points that were just not available to Health Advantage at all. So you're seeing a score of 48, but it's out of a different denominator. Those points were not available, and it was adjusted accordingly. So that's why you're seeing the penalty there.
And I will also say that even though we didn't have, it's the improvement target that we didn't have.
Right.
So if we don't have a number, we can't set an improvement target.
Right.
But I will say that looking back, now that we do have 21, 22, and 23 data, if we had set a target, if we had had the data, Health Advantage would have received 3 more points because they would have met the 4% improvement on 2 of those targets. So they really, we just didn't have a target set for them, but if we had, they would have gotten 51 points.
Right, was not available as of the time of the establishment of the chart and the MOU, so those points were just not available. The penalty that we do see at the very bottom there is a per member month penalty, so that's where we get our total there.
Okay, beneficiary engagement survey. GDIT, the ARHOME program is a Section 1115 waiver program, and that is just allows us to handle our Medicaid expansion population differently than other Medicaid programs. It allows us to use the QHP to purchase QHP coverage for our clients using Medicaid dollars. But as a part of that, of getting the privilege of having that waiver, the federal government says, okay, you can do something a little bit differently, but we want to evaluate how you're handling that. So we contract with GDIT, who handles our evaluation, and that evaluation of the program includes a beneficiary survey. In 2022, they put out 4 rounds of mail surveys between September and December of 2022, and then they even did additional electronic surveys in January and March of 2023, and they received a total of 205 responses. In 2024, they did 2 rounds of mail surveys administered between in March and April of this year, and they received 583 responses. So we're about to show you some survey results, but the numbers of people are 205 in 2022 and 583 in 2024. So these were questions that are national questions that are used on every Medicaid survey. They're very specific about having to say exactly the right wording on these questions. But so I'm just going to give you a sense of the questions that elicited these responses. So the one, I'll also start with the one on the very left. The question was, using any number from 0 to 10, where 0 is the worst healthcare possible and 10 is the best healthcare possible, what number would you use to rate all of your healthcare in the last 6 months? So, so you'll see that, let me go through all of them. The second question is the same question, but how do you feel about your personal doctor? That's not the question, but it's the same question, but personal doctor is what's asked. And then specialist, the question asks about, quote, the specialist you talk to most often in the last 6 months. And then finally, health plan is rate your health plan, and in parentheses, it says Medicaid. And again, these are questions that we don't get a choice how to word it. That's the wording that we have to use. And so you'll see that people liked their personal doctor. These are respondents who rated their personal doctor or specialist an 8, 9, or 10. So people really liked their personal doctor and their specialist. They were not as crazy about their healthcare or their health plan, and there was a significant decrease in 24 compared to 22 in the rating of your healthcare overall, and in your health plan, rate your health plan in parentheses Medicaid. So that is, there may be some feelings about the public health emergency unwind, people being disenrolled, and I've got to re-enroll myself, whereas for the last few years they haven't had to do that. That might have caused some disagreeable feelings. This question is about, these 2 questions are about beneficiary incentive awareness. So the first question is, did your health plan offer you any reward for healthy behaviors or wellness screenings, such as a mammogram or colonoscopy? And you can see that the awareness went up in 2024, the awareness that their health plan was offering them a reward went up in 24 compared to 22. which is good news. I think that's something that the QHPs have tried hard to improve upon. And then the second one is, did you know these, of the people who said yes in the first question, did you know these rewards or credits are part of the ARHOME program to improve the health of members? Again, we saw an increase in people who responded yes to that question. Okay. If there are any questions online or in the room before we move on to the strategic plans? All right, let's move on to the strategic plans. I'm going to start with Blue Cross. And you want to come and work this?
You might check the chat. So.
Mackenzie's checking chat for us. Yes.
All right, I kept it a little warm.
I asked the same thing.
No problem.
Yes.
I'm driving it today because there's 43 slides and I don't want, I don't want to keep saying next. So I'm going to get through this quickly. I did try to abbreviate it a little bit, but we did enhance our strategic plan a bit this year. It's in a different format. We've got lots of images. We're using data to inform all of our changes we've made, and we're really working harder to align with the priorities in Arkansas to improve overall health. So you'll see within the plan that our health incentives are all informed by data and our quality metrics. We've improved, we're using a lot of unique programs to meet our members where they are and improving access to care. And that's a part of the whole person approach, and always pointing our members to their providers to provide that whole person care. And then we also have a significant part of our strategic plan involves communication. And we're trying more this year to communicate with our members and see what kind of communication do they like and what's effective. So first I'll talk about our rewards program, and I'm going to do it by section. So it's called Blue Wellness Rewards. It's encouraging health actions that will improve the health of our members. It is directly related to quality metrics. You've seen some of them today in the presentation of the metrics, but we have the required incentives for the 5 populations there in the middle, but we've got more than just the required. We've got incentives for areas that we know that we perform lower on, and we're trying to offer more incentives to motivate members to complete healthy actions to improve quality overall. So here's how our rewards platform works. A member will log on and they'll have a to-do list there in the top left. You can't really see it now, I'm sorry, it's blurry. But you'll see there in incomplete are all the actions that are specific to the member according to claims and what we know about them that they should complete. And then once they're completed, they get moved over to the complete side. So members really do treat this as a checklist, and they're trying to earn their rewards, which is good. So we're trying to communicate more. There's articles to educate, and then once it's completed, it's immediate rewarding upon receiving a claim for something. There are some manual, like the career readiness certificate, for example, that they would have to send in documentation for, and those are sent to our customer service, which will then override and receive reward in a timely manner. Communications is a big part of this. We want to get our members on the platform because what we see is if they're registered for the platform and active on our rewards, on Blue Wellness Rewards, they have higher quality rates overall.
What's your participation rate? How many out of how many members?
So it varies. A member we consider it impacting a quality metrics if they close a gap within 90 days. So we kind of look at it as active status. But as far as registered on the platform, you know, I would say.
Like how many people are using it out of how many members do you have?
That's a good question. I'd have to go look, but I would say it's probably about 20% right now, I would say, that are active on there. But, you know, we're losing members and then they come on and then we're communicating again. So we're encouraging registration regularly throughout the year. And even if they are not registered, the reward is there available to them. And we're emailing them, texting them how much is available on their platform that they can then go and redeem. But the ones that are logging in are definitely the ones that are more engaged overall. So for the data piece of it, we did look at the performance of each a health action. So how are members that complete a health action, how is that contributing to gap closure? So if we have not a big impact on quality, we try to change that metric and just improve year after year. And also we're looking at click rate, so communications. And we can measure percent of our members that clicked on a message and if that's contributing to gap closure as well. So overall incentives, preventive care, chlamydia screening, we are letting them know about test kit options within our incentive. We added a community health worker certification. You probably won't see that we have a lot of members that get this each year, similar to career readiness. So don't expect a lot on this one, but it is extremely beneficial if they did
They can
achieve this.
actually get their CHW certificate through this program.
Well, we educate how to.
Okay.
So, and if they were to submit a certificate to us, we would then give them the $200.
Gotcha.
And so the way we see that is navigating the health system. They're talking to members that are like them. And so we're impacting, I guess you could like member after member and passing it down. So we'll see how effective that is. Reporting your pregnancy, it's $0, but by saying yes or no, they get a lot of other reward options that they could then earn the $225, which I talked about before. And then for these, we're working to make them more timely. So displaying them throughout the entire year. This year, they are more time sensitive and they go away after an event or a diagnosis comes through, but we're offering to more members. And then for the adherence to mental health medications, we want to offer solutions. So not just at the end of the year. We don't think that's very timely, but if they were to complete along the way, that's the purpose of the $60, which I believe is not correct on this. I need to change that, but it should be the $60 and they get 20 for each. And then substance use disorder, same thing, trying to do more timely, rewarding for that. And then the heart failure visit, that is because that is the lowest chronic condition measure that we have. So we're changing asthma to heart failure for next year. And then here you see that we're adding a contraception incentive. We're really trying to work hard on contraception next year and reward members for being on contraception to improve birth outcomes. Member communications is a big area of our strategic plan. Sorry, too fast here. But we want to communicate timely in an effective way. We're looking at our communications, really seeing how, what was the response on and what was the click rate, targeting them to our incentives. We're exploring different mediums. We've had more digital messaging than ever this year. And then looking at new intelligent ways to message our members based on claims and making them member specific. So for this one, I'm just showing you a couple pictures of some of our campaigns. Two-way texting, so conversational outreach. We're getting a higher engagement rate this way. And it's AI technology that we're using. And so while we would get like maybe a 5 to 10% response by just outbound calls, we're getting clicking on things, responding to a text, and then we can talk to them about and educate them about a screening, for example. Claims-based journeys, these are very member specific. So based upon how they respond to a campaign, we can send a message at the right time and in the right way for a member. So if they like to read their emails at 9 o'clock on a Friday night, it might come to them at 9 o'clock on a Friday night based on when they're engaging in the past. We're using data to develop these claims-based journeys, and we can really make them unique according to what their healthcare state is and what claims we see. So communications, strategic plan, there's a lot in here. You can't read the words, but short term is more, what can we enhance that we've already done and get off the ground earlier this year? And long term are those claims-based journeys. We're looking at a maternal health journey, behavioral health journey, those major health disparities in Arkansas that we want to improve and making those into a journey. And then,
And I just want to say that if there's any blurriness, I tried to, I incorporated their slides into our deck. So if there's any blurriness, it might be.
it's not your fault,
Okay.
it's clear right in front of me. Sorry. And so here's the short term, some of the campaigns we want to do for next year. So contact information update. We've realized that maybe about 20% of our contact information is not up to date. So I've asked questions this year about how can we update our contact information. And so we developed a process. We're telling all of our teams, DHS, here's how you contact DHS. I hope you're getting more of these. We are trying to get them to get on the platform or call. We've seen better contact information lately, so it's improving, but we hope to do more next year. And then these are campaigns that we did this year. So test kit campaign, at Women's Health, we want to enhance those and change them for this year. We're putting them on months that are relevant, like self-check month for chlamydia screening, and making it fun that way, and see if that works. Long-term focus are these journeys. So we have 6 journeys here within the box. We have them prioritized in the way we see them. So the top 3 are pregnant women, and we want to really target childbearing age women. So before they become pregnant, or maybe they're pregnant and we don't know, but they receive an email about our virtual maternity platform. So really focusing on those top 3 and getting those claims-based journeys off the ground. We're going to try to do some opioid communications, which we haven't done before. We want to improve upon that. The whole person approach, this is really pointing our members to their providers, addressing not only their physical health, but mental, as well as any kind of social determinants of health and barriers to improving their overall health. And so here's some data from our provider value-based program, one of them. So this is, you'll see here in the blue, the dark blue in the middle, this was our primary care first program for this year. And they are performing better overall versus the gray line that is not a value-based provider. So these value-based providers are, they have metrics that are aligned with the ARHOME quality program. And when doctors perform to goal, they receive value-based payments. And so by aligning our quality metrics to that program, they're working on the same gaps that we are. So the blue line on the left, that's PCMH. That's so prior to 2024, we had some PCMH and some primary care first. And so it's all primary care first now.
But it's Blue Cross.
Yes, it's all Blue Cross. Thank you. Thanks for clarifying that. And then this is my program that I led. So 2023, we did a pilot program with Pharmacy Quality Alliance, where we measured how can a pharmacist impact diabetes control. And we measured how did A1C control improve before and after pharmacist intervention. And so we would send data to pharmacies to see what kind of results we could get. So, they might get diabetes education interventions prompted to them, or we'd tell them that this member is not adherent for their diabetes medication. They need an A1C test now. So can you complete one in the pharmacy? And so we did see from the early results, this was a short time frame, only 7 months, that we saw a 20 to 25% increase in diabetes med adherence. If we can improve that, we can improve chronic condition diabetes control. So 2024, it's I expanded it this year, and we're doing a lot of fun.
Again.
Oh.
Yeah.
Right there.
And so doing a lot of pharmacy engagement. I've been speaking at APA meetings, at the Arkansas Pharmacist Association, and we've approved medical billing of A1C tests in pharmacies. We also pay for contraception in pharmacies as well. So if a pharmacy is easier to visit for a member in between doctor's visits, we pay for those services, and the pharmacist ultimately points a member to their provider and talks to them about their diabetes. So trying to improve access to care overall there. And then finally, we're offering virtual, so telehealth opportunities for our members, and we're expanding that to also be mental health and maternal health as well. Maternal health, I stated before, we're trying to see members sooner and message before they become pregnant, trying to capture those notifications of pregnancy, and we're offering several opportunities for our pregnant women to engage with care between provider visits and trying to point them to OBGYN providers. So we offer a case management program for high-risk pregnancies, and then we offer a 24/7 virtual care provider where a member can see a number of different types of providers you'll see, And then we've started conversations with Maternal Life 360 homes that are starting up, and we've talked to a few of them about how we can work together. So hopefully that can be beneficial. Overall, I already stated this is our care management program, and this is for those high-risk members. And they will then offer additional services. And our virtual care program, this is more about case management. I'm trying to go a little bit quickly. This is our virtual maternity program that a member can engage with. They take a care survey at the beginning and get matched with a care advocate that matches their background, somebody they can relate to. There's multiple languages on the portal. They can speak with them by video visit. They can chat with them. There's lactation consultants, mental health specialists that they can speak with at any time. But this is available to all of our members and a part of our incentive program. And you'll see here in bold, I'll hit these points. We are getting notifications of pregnancy through our virtual platform. A member might be on the platform because they received an email from us and they enroll before we get a prenatal claim. So we can find out when members are pregnant this way. Also, we're engaging frequently throughout the pregnancy. So about 20 touch points per month, and that's way more than someone would usually see their OBGYN or speak with them. And then finally, we're seeing in results that where members are avoiding ER visits because they're able to consult with someone right then to hold off until the next day and get them stable until they can go see their OBGYN the next day. You'll see throughout pregnancy, different trimesters are seeing different types of providers, which makes sense that in the first trimester you would see more OBGYN providers and then shift to lactation consultants or pediatricians. So I think it's neat the variety of providers they can speak with. And then here, this is just an example of a member's experience specific to getting mental health support throughout pregnancy. And we see with our members that are engaged with our virtual platform that we are seeing more mental health events. So that's actually a good thing because we would rather get their mental health addressed there during pregnancy than show up afterwards and before a crisis situation. So we like that about it. And then NICU rates are also lower for both of our program engagements, both virtual and our case management program. And then we're trying to bring it all together by offering behavioral health support and also chronic condition management during pregnancy and the digital platform all at the same time, and then referring them to other case management programs after pregnancy and appropriate providers to make sure they're getting the care they need postpartum. Behavioral health, a lot of incentives have been changed here. We're looking at, they're offered numerous visit and treatment options that we're incentivizing for. I've already gone through these in some detail today, so I'll skip over how we're offering incentives. I think my formatting came through a little bit odd, but we're doing lots of communication campaigns that are different, sending postcards for suicide prevention and communicating and educating about opioids and wanting to increase that more. Also, we're offering 3 free telehealth mental health visits to get them hopefully to try that, but they might talk to someone about their mental health. And then this is 24/7 post-hospitalization support, but they outreach to members and that need follow-up visits and try to get one within the first 7 days is the goal, to get in touch with the members quicker if they have a hospitalization. So we've got a specific place that these members and queue that they would go to. And then here's that Teladoc Mental Health Complete program that I mentioned. And then peer support specialists, if members with, or if people with lived experience can meet members where they are in the hospital or in the community, where we see really good success with following up with a peer support specialist. This is a pilot we're going to do next year to offer legal support to people with substance use disorder. So removing the barriers that might be a reason why they're not seeking substance use disorder support. So a lot of innovative programs we are trying. And yes.
I'll just say about opioids. We have 2 measures that we haven't gone over because we have so many measures. But two that deal with opioids. One is concurrent use of opioids and benzodiazepines, and another one is pharmacotherapy for people with opioid disorder. So this is in line with what we're trying to do. That's the only point I'm trying to make.
Thank you. Yes. Specific to mental health med adherence, we have medication dosing reminders that we just started. So how effective is this? We just started. I don't have any data yet, but if we can send something to their phone to remind them to take their medication or point them to a pharmacist, is the goal here. And we're offering adherence strategies, like this calendar that they can color when they take a dose, or any ways. There's a number of ways they can click and see visual representations about what we're trying to offer to our members. And then finally, improving access to care. I think this is the last one. This is for, we want to meet members in their community. So that's why we do a lot of pharmacist work, offering different providers working together, pointing to their primary care providers ultimately. And we've been putting on some health fairs this year, as you all know, called Take Good Care of Her. So we went to Jonesboro, and we had one in North Little Rock this year. And we had a mama van on site. The response was really good. We saw a lot of good survey about, they loved that we came to the community, and we provided giveaways, and they had a punch card that they went and saw. All of our local community partners were a huge part of those events. We involved all the community partners that wanted to participate with us to come out and serve the members and meet them where they are. Here's more of that. And then test kits, we're exploring. We do chlamydia test kits this year at the end of the year. We want to expand that and extend it to other screenings like cervical cancer screening for next year, and see if we can move the needle on that. And then here's another home visit that we offer our members, for our home-bound members that can't get to the provider. So, and pharmacists, we pay for medical billing of pharmacists for test and treat contraceptives. Pharmacists can prescribe contraceptives in Arkansas, and we'll pay for a consultation with the pharmacist for that. And that's only for 6 months, and then they have to go see their doctor to continue the contraception. So that's to get them started, and then referring to the doctor. And then A1C testing too, as I mentioned before. And then finally, our incentives for economic independence to encourage. And I didn't mention this, but the launch in Civiform, we are making that a part of what we're doing next year. So we're putting it on a rewards platform next year to educate about that. And then we're using it in our opioids pilot for members with substance use that might need to get seek treatment and get back into the workforce, to promote resources and getting a job. Thank you.
Thank you so much.
Quick question.
Yes.
You talked about AI, and I'm just curious, your mix of AI and personally relationship or a real person. So when you talk about virtual platforms, how much of that is AI and how much of it is a human interaction?
So all of our virtual providers, that's all human interaction. The AI is only messages that we're trying to get them to call the plan so we can then educate them. So that's more trying to engage with them. We see that we can't get them on the phone. So if we can get them on the phone and start providing education, that's the goal to the AI messaging. But all of our providers, telehealth platforms, that's in person, and those are real people.
And so maybe the app doesn't use any AI.
Those are care advocates, those are people. Yep, exactly.
Well, I appreciate, I can see the measures and where you're putting, the emphasis related to those measures throughout. And I also appreciate that you're incorporating launch and Civiform. I know this one's a hard one. This economic independence is a hard one because you're not used to this one. But I really appreciate that, the adherence to the goals are these measures. How do we improve those measures in addition to other things too?
Thank you. And we're also educating about the platforms that we mentioned internally, so we can use those platforms to tell our members about them. Thank you.
Thank you. No.
So just an announcement that we have a hard stop at 4. So we're only at 3:30 now. Yes. Okay.
Well, I actually condensed our strategic plan for the presentation. I think the plan I submitted was probably 40+ pages as well, but I tried to condense it down for today so that I didn't have to go through 40 pages from my previous experience. It was a little easier maybe. So our strategic plan, really truly, we attempt to focus on the program goals of improving the health outcomes of our participants through incentives, but I would say also through programs. We know that incentives alone don't drive the necessary change we want to see. So we, as like Blue Cross, we're constantly looking at what new programs we can implement. Sometimes those come with incentives. Sometimes they aren't necessarily an incentive tied to it, but the program itself is of value to the member. And then also looking at incentives and supports to assist those ARHOME participants in moving out of poverty and up that economic ladder toward independence. Obviously, being extremely, the healthier you are, the more likely you are to be able to do that as well. So we focused our strategic plan around both existing programs in the presentation, and then on new programs that we are implementing in 2025, or we've implemented in late 24 and will be in place for a full year in 2025. Those new programs really are around these areas here: maternal infant health, some new SUD programs, some social determinants of health, and behavioral health. We'll talk about those here in a minute. So these are existing programs that we have in place. My Health Pays is our platform that we use to reward members monetarily for different activities. They can use these rewards to either buy things in an online store, they can convert those to dollars, and they can use that money for specific items, primarily things here, co-pays. This plan doesn't really have deductibles or co-insurance except for out-of-network, so it's primarily the co-pays they might use the money for, or to pay their utilities. They can use it to pay their cell phone, and they can also use it for transportation, childcare, some education things. So it's not open-ended for use. They can't, buy alcohol and tobacco products with it, for example, but it is locked down. So. And then it's focused around typically these 4 areas about eating right, being well, moving more, and saving smart.
So same question for you. What percentage of your membership is actively signed up on this platform, do you think?
About 16%. That, I will tell you, is up a little bit from the previous year. I think through really trying to educate, we're continually trying to educate members and assist them with getting connected to the program. And it's actually about 2% higher than we see across all of our other Centene markets. So again, while programs are necessary, they don't all participate just because there's offering an incentive, unfortunately. It's hard to believe sometimes that they don't more take an action here just because it is real money and they can use that money in real ways. But we certainly don't see everyone taking us up on that.
And you say Centene markets, you mean other states?
Other states, just across our marketplace, this is part of that program as a whole, which I was surprised. I thought maybe, we were low, but turns out we're actually a little bit better all in all. But we continue to try and increase that awareness. We've incorporated it into our scripts when our quality teams are reaching out. We're constantly reminding folks that they can earn a reward for those things, and that they can, if they're not signed up, we can help them right then get signed up for the program. This a little blurry, but really it's around,
We're blaming Zoom at this point.
We're going to blame Zoom. There's really a couple of ways to earn these incentives. Some is actually healthy activities like going and having a wellness visit, or actually getting your cervical cancer screening, breast cancer screenings. Those kind of things earn you a reward. But also participating in our various case management programs will earn you a rewards. We are trying to encourage people to take advantage of those programs. And then there's also within the member portal, there's what we call challenges and power-ups. And these are actually educational videos that if they participate with those, they get rewards for just watching the video and learning about the different things. The power-ups are weekly. So literally every week there's a new educational video about something. Sometimes it's about, having a wellness visit, but other weeks might be about how to save smart or how to save on your electric bill. So lots of different educational topics for the members to take advantage of. We also have provider incentives programs that we are running. These are existing programs. We have our continuity of care program. This focuses on our primary care doctors, where we actually provide them what we call an appointment agenda. So when you bring them in for an appointment, these are the things you should cover. These are their open gaps. This is potentially if they had med adherence issues. These are areas of focus. Our quality teams are continually meeting with the primary care doctors on the daily. Angel can speak to that. Once a month, they're attempting to reach out to those large primary care clinics, and they're going over their appointment agendas, and they're also making sure that they're logging into our pharmacy programs to see if they have members that have open medication adherence gaps. We have in-office assessment programs. This is another incentive program for providers to just make sure that they're assessing and documenting all those member conditions appropriately so that we are aware when the claims come to us what conditions those members do have, even though it may not be why they went in for the visit. It's also documenting other conditions that they may have that are notable. And then our value-based care program. This one is actually focused on behavioral health. So it is with some of the larger behavioral health clinics where they actually receive bonuses for seeing those individuals that are associated to them for their behavioral health needs. We have the ability to actually send them eligibility on a monthly basis and different things so we know exactly what members are assigned to those provider groups. And then continually working with them and providing reporting so that they know how those members are performing. Then this is these are our existing programs all mushed together.
Showing terrible.
No, but I'll just walk through them.
So again, I carried it in with the formatting. That's like the Elizabeth showed. So I apologize.
It looks right on her screen.
No,
Does it not?
no, it's kind of mushy. That's okay. I'll just walk through them real quickly. We continue to work with the Workforce Development Board. We do a lot of community activities where we do health fairs in the community. When we go into the community, we bring community resources together typically. We invite the workforce development group to be there on site. These are community events. They're not necessarily just for our members, even though we do invite our members specifically to come out to the events. They're open to anyone in the community to attend. At those events, we have the memo vans are there. We have people that are doing screenings. We have the development board. So lots of healthy activities taking place when we have those events. And so the workforce group has partnered with us and attended a lot of those community events with us. Next is notification of pregnancy. We talked about that a little bit earlier, but we have just multiple entries into our systems for members to notify us about their pregnancy. And now, as we talked earlier, and we'll talk about in our new programs, one for providers as well. So how can we find out quicker, sooner that a member is pregnant so that we can get them enrolled in our Start Smart for Baby program? That's the next one. That is a maternity case management program that's very intensive, high touch for our members that have potentially high risk needs associated with the pregnancy, so that we are continually talking with them, making sure that they're receiving the care, going to their visits, and taking advantage of all the other programs that we also have available. We have a digital program called WellFrame, so that if they're curious about something, they can always get on that. check that out and get a lot of information, but also making sure they're connected to our Farm Box program we talked about earlier, and those other baby showers that we do, those types of programs, so that those pregnant moms are taking advantage of all the opportunities to be educated as well as receive the healthy incentives like the food boxes, or through the baby showers, they actually get car seats and things such as that too. So really ties that all together. The community baby showers I just mentioned, and then the METS program I hadn't mentioned yet. That's Members Empowered to Succeed. That's a behavioral health program that is a case management program targeted to those individuals with significant mental health needs. These are also additional continuing programs that we have. We have a HALO program that, again, is a case management program for members with substance abuse disorders. The pharmacy lock-in program, we have ran this program for several years. This actually is targeted at those opioid, the members with the opioid metrics, where it identifies a member that through data is at risk for going to multiple pharmacies to try and get multiple scripts filled. It actually locks them into a single pharmacy, so that single pharmacy then is managing their script needs, and that they're not actually able to, get multiple scripts for those opioids and then go to multiple pharmacies to get those filled. Really has manage those members that are managed through that lock-in program. We have seen substantial adherence to bringing down some of that activity. Well-framed digital case management, I just mentioned. That's our online tool, digital case management tool, where members have access to go on to that site and get lots of resource information about multiple conditions. It's not just maternity, it's all the other chronic needs conditions as well. So there's asthma, diabetes, behavioral health. There's lots of information in that digital case management program. We mentioned the in-home assessments already. Choose Tomorrow is a suicide prevention case management program. And then Find Help. That one was launched in 2020, early 2024. That is available on our website. It's actually available externally to anyone, so it's not necessarily our members that have to use it, but it is on our Ambetter website, and that platform helps individuals. It connects them to those social care needs, like finding groceries or childcare or food banks, things in their area. So if they're having any kind of need assistance of any kind, they can go on Find Help, go to their area, and see what's available around them. It's really a great tool to help connect members to those needed resources.
Did you all contract with Find Help just in Arkansas, or is that a national relationship?
National. But it's Arkansas specific when it comes to implementation.
Right, when it comes to searching resources.
Yes, yes. So the new programs, these are the exciting new things we're bringing. So PICS Health is a new program we are launching. It is set to go live in early January, so it's not actually live yet. This is truly a new program implementation for 25. This is for members that have loneliness needs. And so it's available to all the members. It'll be on our website. We will be educating our members about this particular program, but we will be targeting specific members that have, through the data, have criteria that would indicate to us that they may be more susceptible to loneliness. We are running this program, Centena's in other states, and have found that it's been very, very successful with members that just really need to talk to someone. They just want somebody to talk to. It's a human, it's a person on the other end. They can call them. It's 24/7 availability, so they can call them if they're feeling down for whatever reason. They just want to talk to somebody. It's companionship. But the data, what we're seeing in the data in our other states, is that members that are participating in this have improved mental health needs and lower medical needs as well. So really a lot of success around this loneliness The other thing that we're really hoping that we're able to target as we get more members that have built relationships through the PICS Health with this population, that we will be able to then target some of the gap closures needs with this population. So if we've built a relationship with them through the loneliness, and then we see they do have a medication adherence need, we can then utilize that to through data to be able to say, hey, the next time we talk to this individual through this program, we need to make sure we're encouraging them to take their meds. We can see they haven't picked them up. We know they haven't. Sober Sidekick is similar in that it connects people, but it does this through an app, kind of like peer support. It connects them to other individuals that have been on their same journey, and gives them a platform to engage real-time 24/7 virtually through an app with others, so that it helps to encourage their motivation and accountability. It also has some predictability capability to say this person looks like they may be going to relapse, and then provides them information to help them connect to our nurse hotlines and things like that if they feel like they're relapsing, so that we can connect together with them to try and prevent that relapse from occurring. A lot of excitement around this particular program as well. And then lastly, we have launched in November an Ambetter mobile app. The mobile app does kind of the things you think. Members can check claims, they can get their member ID card, but also it's going to allow them to see their My Health Pays, all those rewards, so they can see where they're at, rewards they haven't actually received and potentially could, and then also activate the account and accept those terms and conditions. That's a very key component. Members have to opt into that program for us to be able to provide them funds and things like that. So we feel like the Ambetter app will increase, hopefully will increase our participation with My Health Pays as well. We are launching a transitional care management program. This is another case management program. There are rewards available through My Health Pays for members that do participate in the case management programs. This one is specifically targeting high-risk substance use disorder members that are receiving inpatient treatment, to connect them to develop a better care plan, so that when they do discharge, we are connecting them with the services that they need to continue once they have discharged, in an effort, hopefully, to reduce those readmissions and enhance their overall quality of care. MammoVan partnership, that we have had a partnership with UAMS, but we have extended that partnership with Baxter Health up in North Central Arkansas. They also now have a MammoVan, which again, going out into the community, attending the community events, anywhere that we can connect members to that MammoVan, so that they can get those breast cancer screenings more easily. We've talked about the notification of pregnancy program a little earlier. Again, that this is the provider notification of pregnancy program, where we are incentivizing providers where they can receive $100 for each of those completed NOP forms for their members. And then also we have implemented, and this is more communication, but they also get a little free gift for doing this. So we have put the little QR codes all over the place, health departments in our OBGYN offices, at the FQHCs, really saying, here, notify us that you're pregnant, and in doing so, you'll get a little small gift. So we are, again, trying to incentivize. We have just launched this, and we have already seen a huge uptake on members scanning that QR code, more so than some of the other things that we've done. So they maybe see it, I guess. We don't know, but I know that Angel and her team can attest that we saw a lot of uptake on that QR code.
I will add to that, so I just want to add a little light to the QR code. So we basically wanted to have it saturate the communication of how to communicate back with your provider, just all over the state. And we went into health departments, rural health clinics, FQHCs, everywhere, provider offices, and put this QR code up wherever they will allow us to come up. Do you think you're pregnant? Are you actually pregnant? We have a gift for you type thing. So they scan the QR code and then they are directed to our website. They're prompted to our website where we are able to accept their personal information. Just as Kim stated, the sooner we know, the better. Literally, you can go to the health department and get a positive test. Didn't know I was pregnant. Leave out, scan the QR code, and you get a gift. So the gift is just a little incentive, but the most important thing is having their information, knowing that our member is pregnant, and then being able to reach out to them for a Start Smart for Your Baby program, car seats, baby showers, etc. It's just an earlier notification so we can really engage that member.
And make sure you let DHS know.
Let everyone know. Yes, yes, and then hopefully too, we'll be able to utilize that information even sooner than a claim. And as we're working to be able to provide DHS on a daily basis with everyone we know is pregnant, it's just more members we're able to identify earlier in the process, so.
Just out of curiosity, what is the gift? I'm sorry, you just keep saying.
I was wondering that.
Yeah.
It's a new mom gift basket, so it varies. Kim said this as well. We had surprisingly a huge uptick. I keep seeing payments coming across my desk, but it ranges from a basket with bib, lotions, water bottles, just, various things to help a pregnant mom. So if you type in new mom gift, it's typically those types of more generic gifts. So they get something right away. So we're not discouraging them from communicating with us immediately. But again, the most important portion is to make sure that we know. So yeah,
Right.
it's just it's a cute gift. It's about under $50 basket of trinkets and
But
such.
then we're telling them, that's the other piece, when we are talking to them, once they opt into that, with the QR code, we have someone that's reaching back out to them and they're telling them about our Farm Box program, trying to get them engaged in that.
Start Smart for Your
Start
Baby.
Smart for Your
baby showers,
Baby, so we're trying to
showers.
just more communication, I think, the more you can talk to them, the more you get them engaged, the more they're likely to actually take an action. The other thing about our Farm Box program that's so cool is that we customize the communication pieces that are going in those food boxes. And these are big food boxes. They're not just, a couple of things. These are either big fresh produce boxes, they're pantry staple boxes. They get to choose what they would prefer to get, or they're prepackaged frozen meals. They can get that as well. But what's in the box is custom pieces of communication that we have tailored to the timing of the box. So the first one really talks about the things you should be doing throughout your pregnancy, but the further you get along, then you're getting information about how to take care of your newborn. And then the delivery box actually talks about restarting your contraceptives and things like that. So really targeting all those metrics around the babies and the restart your contraceptive metrics. So that is what we, as much as anything, we know they're opening the material because they're opening the box. Now, whether they read it or not, but a lot of times we feel like, we target members with so much information that at times you don't know if they actually read it or not. But in this case, we know they're opening it because they will open the food box. And we've gotten a lot of really good feedback from members on this program. So we're excited to see it just grow. The Farm Box program went live in April, so we weren't a full year in 2024 with it. We will be a full year in 2025. And we do think there's other opportunities to extend beyond maternity. Maybe some of our diabetes programs and things like that could benefit from the Food Box program as well.
And just a quick time check.
Yep.
Yeah.
I'm done.
To totally cut you off.
Were you actually done?
I am done.
Okay.
I'm actually done.
You are, okay.
Okay, good. Okay, I mean, so we didn't cut you off.
No, I was done. We'll let Secretary Putnam close us out.
Yes, so thank you all for bringing your strategic plans. I know that there's been a lot of work done on these. I think as we process more through the metrics and everything for this quarter, I'm sure we may reach out with more questions. We had a robust discussion yesterday about just what some of the implications could be on the decrease in the contraceptive rates, the uptake on contraception. We may have other questions as we go through this, but do we have any questions in the chat? Anything? Okay. Any other
While you're
questions?
looking for that, could I just offer a comment?
Yes.
Sitting here listening to the strategic plans, I remember the very first strategic plans. And I think Matthew just had a big grin on his face.
It's a little better, isn't it, Dennis?
Which was, again, calling them back and
More
saying, are you sure this is what you're sending in? I mean, the improvement in the quality, the thoughtfulness, the creativity, just really, you all have made such a huge, huge advancement in your strategic plans. I just wanted to make that observation of how much work you all clearly have done in improving.
Thank you. I wish I had seen that.
I'm
Thank you.
actually.
Do we have a recording of that?
I'm sure that we have it, it's public record.
I mean,
But yes, I echo Dennis's sentiments about the amount of work we know that goes into, looking at your own data and what are we gonna do to improve these different measures. And, of course, we always acknowledge the fact that there's choice involved and member choice involved and that's with any of us, but, we know that we've talked about the Medicaid population and just some of the challenges that we have seen with our incentivizing and trying to get people to use the care that we provide them. But appreciate the thoughtfulness in these plans, so thank you. And thanks to everybody on the team who has been participating in this and helped put this meeting together. And we always do a pre-meeting. You guys, we don't subject you to the pre-meetings, but we always do a prep meeting. So it's always a chance for us to kind of talk beforehand about some of the questions that we want to ask. But I do think, and we have some broadened participation in this one this month. We had some additional legislators express interest during our budget hearings. We've had some additional stakeholders, and so I think we've got a larger group today than we normally have had, and there's continued to be, as everybody has seen, a significant interest in our healthcare system, our manner of providing the healthcare, the outcomes. Are we getting healthier? Are we not? And what can we do about it? And so I think we'll continue to hone in on, how can we improve and how can we work together to make sure that people who have coverage are actually using it. So, yeah. And with that, unless anybody has anything else.
Just make sure we don't have any chat comments.
Nothing else? Okay. All right. Well, thank you all very much. I'm running off to my next meeting. And we appreciate you guys. Merry Christmas. Happy New Year.
Thank you.
Thank you.
On the FTC,
Thank you.
Perception about people just using LTCs. That would bypass
yes.
that.